So when we talk about cancer in our office, and really it's the same thing with any chronic patient, any patient we take on our larger plans, there's 4 pieces that I call pillars that we have to deal with. So there's 4 pillars. So it's easiest to explain with cancer. The first pillar is what is the cause and how are we going to get rid of that? So when you're dealing with cancer, there's always a cause. Now, from a standard oncology approach, that is completely ignored. Unless you donated your body to science after you died of cancer, and that's what they're doing the study on. For instance, H. pylori, which is a gram-negative bacteria in the same family as Lyme Borrelia, is the #1 cause of stomach cancer worldwide according to the World Health Organization, based upon numerous studies on the causes of stomach cancer that were funded by some pharmaceutical company wanting to kill H. pylori, probably. But otherwise, it's completely ignored. They don't even still, if you had come in to the oncologist with stomach cancer and you came in and said, "Doctor, here's a paper from the World Health Organization that says the #1 cause of stomach cancer worldwide is H. pylori infection. Are you going to treat my H. pylori infection?" He probably, again, either throw you out of the office or he'll say, "Yeah, we'll look at that, and here's the chemotherapy that we're going to do." They still, even having that knowledge, they still don't treat the cause. Do you understand? To me, it makes no sense. If you have a cause of cancer, there is a reason why. So understand what cancer is. Cancer is a normal cell that is, for some reason, is not going through normal programmed cell death, apoptosis. It is in a state of rapid replication, which in itself is a state of an issue with methylation. So the idea of how a cell replicates, every cell in your body will replicate a new cell, and the mother cell will die. And that is how your body survives. You slough off skin cells because you replicated new skin cells, and the other skin cells died and they sloughed off. That's called apoptosis. That's a neuroprogrammed cell death. If a cell doesn't go through apoptosis, normal programmed cell death, and it, for some reason, is in a hypomethylation of the DNA replication cycle, it will be in a state of hyperreplication. That is, by definition, cancer. That's what cancer is. Cells not dying and hyper-replicating. Why? There's an issue. There's a genetic issue. There's a toxicity issue. There's some chemical toxicity. There's some infection. There's something is going on. We need to address that piece. So that's pillar #1. What's the cause and how are we going to get rid of it? And I believe you can find out that answer. #2 is what are we going to use from a nutraceutical standpoint? So I'm an alternative cancer doctor. I don't use chemotherapy. So what are we going to use from an alternative chemotherapy? A nutraceutical. Something from a nutritional standpoint that's going to specifically affect the cancer itself. There's lots of things out there. Are we going to use Rick Simpson oil that somebody brought up to me before? THC? Are we going to use Hoxie? Are we going to use Laetrile? Are we going to use, there's 20, 30 different possible nutraceutical cancer killers out there. So we test for what that is. What are we going to use specifically? That's the second pillar. What are we going to use for the patient?
How do you test?
So I test using a specialized form of kinesiology. Thirdly, I use the Rife with every cancer patient. What frequencies are we going to use? So we decide what frequencies we're going to use for that patient based upon scanning them. And we are the ones that developed that scanner that I think Mike has out here with the electrodes that you connect to K27 point. And we scan for frequencies. That's one way I determine what frequencies we're going to use. There's known frequencies for that specific cancer. We're going to use that. We're going to use frequencies to support adjacent organs and support detoxification pathways and support the kidneys and the gut, etc. And we're going to use some other frequencies depending on what else I want to, whatever I tested as the cause for that cancer, will help support that, and some other things that I want to put in that program. So I personally write every single person's program, and I write night programs, so they're running the programs while they're sleeping. So I personally, it's just my philosophy, I don't want my patients rifing all day long. I want them living. I mean, what good is it? Why am I going to stay alive for another 5 years with this cancer if I have to sit in front of the rife machine all day long? That's not living. I want them living. I want them to go get their job back. I want them to be a productive member of society. So that when you can rife, you can do most of your treatment at night while you're sleeping. You got to sleep anyhow. Yes?
Do you have a generalized favorite detox program?
Do I have a generalized favorite detox program I do at night? No. I don't. Sorry. I don't believe in protocols, okay? So I want to build a protocol around the patient and their needs. So that's the third piece, rifing, using the rife. The fourth piece is a hodgepodge, especially for cancer patients. We got to look at their genetics. We got to look at what diet we're going to put them on. Do they need to be on a low methionine diet, a low glutathione diet, a glutamine diet, a low sugar diet? What do we need to do with that person? Is diet even driving the cancer at all? Sometimes it's not. What do we need to do to support the liver or the gut? All the stuff that we talked about today, it just goes on and on. Are we going to do coffee enemas? Are we going to, and then there's an emotional, spiritual side. We need to support that too. If you can't get out of this terror in your mind, you're never going to get better. We have to balance the sympathetics and parasympathetics. That's the other side of your nervous system, your autonomic nervous system that controls all organ function. So if a person's in a sympathetic dominant state, we have to pull that down and balance that and stimulate vagal nerve function. So there's a lot of different pieces to that fourth pillar. But those are the 4 pillars that we go through, and it takes 2 days in our office to really sludge through most of that. Patient goes home with a rife machine. They start using it every night. They go home with a 3-ring binder with their program and their protocol, and they're following that. And then as we get the gene information back, we tweak it and we add that, and we just keep tweaking their program. And if the patient continues to do well and was supposed to be dead 3 months ago, and now they're doing great, now it's 6 months later, 12 months later, we just continue on. And that's our goal. So I don't believe I cure cancer. I don't. I don't believe that anybody cures cancer, but I do believe that you can manage it and turn it into a chronic manageable disorder that you can continue to live long after you are not supposed to be alive. So that's our goal. So that's what we do for patients that come in our office. Lyme, it's very similar. Lyme, you have to deal with some other things that you don't have to do with cancer. Lyme is more difficult to deal with than cancer. And I've said multiple times, and my Lyme patients get mad at me, but I'd rather have a stage 4 cancer patient walk in the door than a chronic Lyme patient, because they're easier to fix. Easier to fix. So with Lyme, you have to deal with a lot of inflammation in the brain, and that's when you have to build brain pathways, and that's where, using home brain-based therapy, and I have a home brain-based therapy manual that we send home with patients, and sometimes a neurofeedback unit that we send home with patients. All right.
Is that one of Mike's neurofeedback?
No. So Mike's program uses brain entrainment. So let's touch on that a little bit. What is brain entrainment? Your brain, from a electrical perspective, fires at different hertz. That is cycles per second. So when I'm going to fall asleep, I have to be down at about 4 to 5 hertz. That's an alpha wave. When I'm like all excited at a seminar listening to Dr. Connors, wait a second, everybody's really at 4 hertz. You're at about 25 hertz. Okay? A beta wave, a high beta wave is about 28 hertz. That's when you're really concentrated, you're really excited, you're playing basketball, okay? You're really concentrated in a game, you're excited, right? You're at a very high frequency at about 28 hertz. Do you realize you're watching this screen all day? This is brain entrainment at 60 hertz. Screens, all screens, television screens, telephone screens. iPad screens. Every computer screen type thing is functioning at 60 hertz. You are training your brain at 60 hertz. So this is another thing. We have an ADD, ADHD child. They can't use screens. We limit their screen time. You can get blocking glasses, dark amber sunglasses that will help block some of that. None of it's perfect. You got to limit screen time. This is one of our problems in society. Is it a chemical issue? Yes. Is it a discipline issue? Maybe. Is there other, toxicity issues, vaccine issues, all these things? But the kids aren't going outside playing anymore. They're not playing in the dirt, building their immune system, grounding themselves. They're in front of screens, watching computers, playing video games, looking for Pokemon characters.
Is that 60 hertz because of the...
That's just how it's made. They're all made that way.
20 volt, right, 60
Yep.
hertz, okay.
You are training your brain at 60 hertz and think you're going to drop down to 4 hertz and go to sleep. This again adds to early dementia. It's very excitatory to your brain. Neurofeedback is different than brain entrainment. Neurofeedback, you're specifically connecting leads to whatever part of the brain that you're trying to fire, connected to a piece of equipment, connected to a computer. Yes, you're getting screen time, but you're only doing 20 minutes of it. And you're actually turning that movie on and off with your brain. So if I'm connected to my FP1, FP2 right here, that's firing my prefrontal cortex. So if I have prefrontal cortex issues, I can purposely train my prefrontal cortex. Or if I have chronic pain issues, I can purposely train my parietal lobe.